How can this thing be affected? That's the last little bit that we got for today. How can we affect the output to the heart? There are a number of ways that we can do this. Okay. There are a number of ways that we can do this. And we'll look at all that. And that will affect blood pressure. And that will affect how hard the heart works. And what that's going to do ultimately to other systems within the body. Urinary system. Because we're going to affect kidneys. It's going to affect the cardio. It's going to affect your lungs, how fast you're breathing. Okay. So cardiac output is a pretty important concept. I know it was asked quite a bit on some board exams and NCLEX and stuff like that a few years back. Cardiac output, again, is just that stroke volume. It's the amount of blood pumped in a single ventricle in 1 minute. It's measured in liters per minute, and you can see it down there at the bottom. Okay. Cardiac output is important to kind of understand and know because it really lets you know how effective the heart is as a pumper. If cardiac output drops below a certain amount, then that's going to be a detriment to how you perform as an athlete. It could be a detriment to how you get blood to your brain and survive and stay awake. So this concept of cardiac output is pretty important. You can use it to even figure out your fitness level as well through some fancy pants measuring the math. But for cardiac output, it is determined by two major things. Heart rate and stroke volume, the amount of blood projected per minute. And our heart rate is, again, initiated by the SA node. And I established that earlier, and that is 75 beats per minute on average. Okay, on average. If it's less, great, you're just effective. If it goes faster, then there may be some issues potentially. Stroke volume, we already established that earlier. Stroke volume was 70 milliliters per minute. So what does that equal? 5.25 liters per minute. Okay. So cardiac output equals heart rate times stroke volume. What's your heart rate? 75 beats per minute. What's your stroke volume? 70 milliliters per beat. As you can see, beats get destroyed, crossed out in the math, convert milliliters to liters, and we have 5.25 liters per minute. That's a number that you probably should remember. That is your cardiac output for a normal individual person. If you're an athlete, it can go way up high. If you're not a weekend warrior, but if you're an athlete, you can get that cardiac output to be a pretty significant amount, very high number. Cardiac output is important for the body to maintain because it ensures that it meets the tissue needs for oxygen, delivering oxygen, nutrients, and just as important, getting rid of waste products. But it is important to meet the tissue needs, whatever that demand is. Okay. It will depend upon your sex, how old you are, the size of your heart, your training mechanisms. Okay. Do you do endurance training? Do you not do endurance training? Do you not run and do anything? There are a number of things that can go into and affect the cardiac output. And I have some of those up here. If you have a smaller heart, you have a smaller stroke volume. You have less myocardium. So I hope that that would make sense, that the amount of stroke volume would be a little bit smaller. To compensate for that, your heart rate goes faster. Babies' hearts are super small. If you ever listen to a baby's heart or a child's heart, I mean, it's going like 1,000 miles a minute. And that's because it has to pump faster to push the same volume of blood. Same thing with a woman. Women generally have a smaller heart than men. Not by much, but a little bit. And so they're going to have generally a faster heart rate. Take that woman and she trains for endurance training, and heart's going to get a little bit bigger because of the increase in activity. It's going to be a much more stronger heart, and they can develop a slower heart rate. So I get it. Okay. Not every woman has a fast heart rate. All right. These are in general terms. My wife, she has a slow ass heart rate. It's insane. Okay. She has a very effective heart. Not me. Not me. Cardiac reserve. What is cardiac reserve? It's just this, guys. This is the ability to increase cardiac output above rest, which is good because if you're going to run to the other side of the room, you're going to increase the amount of cardiac output that you're doing. Just getting up out of a chair and walking across a room increases the cardiac output from just sitting there like a bump on a log. Cardiac output really or cardiac reserve, sorry, can be used to be an indicator for health for certain types of medical conditions. So, it's determined by figuring out pressure ejections and systolic and diastolic and comparing that to those so there's a lot that goes into it. So I'm not asking you to calculate it. I'm not asking you to, tell me somebody's cardiac reserve. I want you to know what it is. And it is important because as soon as you get up and start being active, you're going above and beyond. And your ability to go above and beyond is that cardiac reserve, right? It just gives a measure of fitness. It gives a measure of fitness. Okay, fitness. If you have to ask like in those commercials, ask your doctor if your heart's healthy enough for sex. If you got to ask it, you're probably not. All right. And one of the things they try to figure out, they look at your blood pressure, and then they try to figure out pressure ejection. So they're going to, hook you up to a device and just kind of measure, what happens electricity wise in your heart and the amount of blood that you're pushing and all that. And they use that to figure out cardiac reserve. For us, a non-athlete individual, well, for you guys, I'm an athlete. No, I don't know. We can increase our cardiac reserve by 4-fold. That's quite a bit. For a non-athlete, they can push an even huge greater volume of blood, 7-fold. That's a huge amount of blood that their heart can effectively push through the system. Where in the hell is all this blood coming from? Shockingly, you already had it in your system. As muscles start to contract, they exert a pressure. And instead of all that blood engorging inside that tissue, because the muscle is contracting repeatedly, it constricts those blood vessels. So all that volume of blood stays within the blood vessels. So this huge cardiac reserve that can happens just naturally, and it occurs with the blood that's already there. Instead of going into the muscles, it stays within the blood vasculature, the blood vessels. But still, that's a huge volume of blood that the heart has to pump now. And depending upon your degree of fitness, depends upon whether or not your heart is able to pump a big volume of blood effectively or not. So this cardiac reserve is not all of a sudden you're manifesting blood from nothing. It's just that this is blood that now doesn't go into tissues because of the contractive forces of the muscles, and that pinches the blood vessels. And so blood doesn't go into the muscles anymore or as much. And it stays within the blood vasculature. And if it stays within the blood vasculature, that means the heart is the sole responsibility is to push that blood forward through the system. And for athletes who train effectively, their hearts can be very effective, and you can see they can pump upwards of a hell of a lot more blood than we can. If you're somebody that trains all the time and not just a weekend warrior, then you can get up into that 7-fold increase stratosphere. Okay? I'm not saying you can't. It's just that for the vast majority of us, we don't necessarily train that way. And if you don't train that way, you're not going to become that thing. We have a number of various different things that can affect how the heart does its actions. Chorionotropic agents are one of them. These are drugs. Drugs, man. Okay. Norepinephrine, epinephrine, neurotransmitters, neurochemicals, chorionotropic agents. Okay. Chemical agents.
What does that say? I'm sorry.
Drugs.
Okay, thanks.
Yep. Chorionotropic agents can be chemicals, drugs, norepinephrine, epinephrine. They're our body's own chemicals. We have chemical agents that can be both positive, and we have chemical agents that can be negative. We've already seen this. Okay. These are the autonomic nervous system. Sympathetic, parasympathetic involve the secretion of different neurotransmitters, different chemicals. Positive chronotropic agents increase heart rate. Positive chronotropic agents increase your heart rate. So they speed it up. These are sympathetic nerve stimulations. This is norepinephrine. This is the adrenal gland releasing epinephrine or norepinephrine into the system. These are positive chemical agents. These are positive chronotropic agents. And these help to increase the firing rate. They increase the rate of contractions. It's sympathetic. You are fighting the bobcat or you are running for your life from the bobcat. We already talked about terms of sympathetic and parasympathetic. We're just adding another specific tiny little layer to it. They're referred to as chronotropic because there's caffeine, there's nicotine, there's thyroid hormones, there's a bunch of illicit drugs, cocaine, one of them, one of the major ones. So there's a lot of positive chronotropic agents. Not all chemicals are naturally occurring chemicals. Not all are good chemicals, right? Norepinephrine and an epinephrine bind to adrenergic receptors. Okay. And this kickstarted a secondary messenger system. And there are a number of them, and I am not asking you to know adenylate cyclase, cyclic AMP, protein kinase. I am not asking you to know any of those cascades. It is a secondary messenger system. And this secondary messenger system, when it comes to positive chronotrophic agents, increases the fire rate. How in the hell do we do that? By bringing in more calcium from the extracellular space into the heart, whether it be the myocardium or whether it be the nodal cell, it doesn't matter. Calcium influx was the major thing that caused everything to fire. Fire quickly in the nodal cells and fire for a longer period of time in the myocardium. Positive chronotrophic agents. These are chemical agents. Norepinephrine, epinephrine, adrenaline. These all increase the heart rate. They bind to adrenergic receptors. This is what increases the fire rate, causes a G protein coupled reaction to basically bring in more calcium. More calcium, faster nodal depolarization. More calcium, longer, stronger contractions for the myocardium. Okay, and here's this mechanism here, norepinephrine binding to, as you can see, it's a beta receptor. I'm not going to ask you beta receptor, all right? But why are beta blockers given to an individual with heart issues? So their heart doesn't go and race like this. Okay, so when you take a beta blocker, it blocks that norepinephrine from binding to that beta 1 adrenergic receptor, so the heart doesn't contract hard and fast. Here's some other ones as well. I mean, these are some of the just common ones, guys. There's a whole huge list of them out there. Thyroid increases the release, nicotine increases the release of norepinephrine. So if you smoke and ingest, put a patch on, whatever for nicotine, this is what causes the heart to race because it increases the release of norepinephrine, which is a positive chronotrophic agent. For thyroid hormone is interesting. It increases the number of receptors on the surface of the nodal cells. So just by a specific type of hormone here, thyroid hormone, it will help to stimulate, how fast this nodal cell will depolarize just by increasing the number of specific adrenergic receptors on it. Caffeine inhibits the breakdown of cyclic AMP, so it allows the heart to kind of continue to contract at a much faster pace. Cocaine prevents the reuptake of norepinephrine, so it stays in the cleft longer. If it stays in that synaptic cleft longer, it's not destroyed, it's not re-upped, so it can continue to stimulate those receptors there. And that, if you know somebody who's done cocaine, the heart races on when they consume it because we don't remove it from the synaptic cleft. It stimulates the heart, but then cocaine will inhibit the digestive tract as well, so it shuts it down. So you don't feel hungry on it. Negative chronotrophic, if positive chronotrophic agent stimulated it to fire faster, fire greater, obviously negative is the opposite effect. What's the opposite effect? I mean, if we're not talking about sodium and calcium, I hope to God you guys know that we're talking about potassium then. Okay. Negative chronotrophic agents are the opposite of positive chronotrophic agents, so they decrease heart rate. This is parasympathetic activity. Acetylcholine gets released, binds to muscarinic receptors. Okay. Those muscarinic receptors or potassium channels. Potassium moves, makes it much more negative. If we get further away from positive, that just means it's going to take a little bit more to fire. So instead of minus 60, it's maybe minus 63, minus 65. Okay. It takes a little bit longer for that nodal cell to reach threshold. Still reaches it. Okay. Still reaches it. It just takes a little bit longer time. And the heart diminishes its activity. Diminishes SA node firing, which diminishes how fast the heart will contract. Positive chronotrophic agents increase heart rate. Epinephrine, norepinephrine, adrenaline are all positive chronotrophic agents. Bind to those adrenergic receptors and cause an increase in activity. Negative chronotrophic agents, acetylcholine, parasympathetic system. Acetylcholine gets released, binds to a muscarinic receptor, opens up potassium channels, inside becomes more negative, takes longer to depolarize, which slows the heart rate down. This input, guys, is only done by one major thing, and that is receptors. Receptors. Okay. These chronotrophic agents, now norepinephrine, adrenaline, acetylcholine, those are you. Okay. You doing cocaine or you doing nicotine or caffeine or whatever, that's coming from the outside, and you're going to affect the body. Okay? Again, chemoreceptors are going to be the major ones detecting that, whatever drug you're ingesting in. Okay. Pick one. Caffeine, nicotine, cocaine, pick one. Okay. But your body has receptors all over the place. And as soon as nicotine, cocaine, caffeine enters into the system, it is a chemoreceptor that's going to recognize it. It sees that there's other chemicals in the body. It's going to send that information up to the brain. In that brainstem, right? In that cardiac center. And that cardiac center is what influences that sympathetic and parasympathetic activity. When it comes to positive chronotrophic agents, we don't just the heart does a good job of regulating itself. Okay. If it's not getting enough blood, the body does a good job of just shutting the system down and doing a hard reset with cardiac output. When it comes to how fast does heart contract, because if I speed up the heart rate, I want you to think about this. Close your eyes, visualize it. Okay. If you increase the heart rate, there's going to be a slightly lower volume of blood that gets ejected. So your heart's going to have to speed up and speed up and speed up to ensure that it gets all of that volume of blood out to get oxygen and nutrients to all of the tissues. Okay. Eventually, it could get to where you are having not enough blood be pushed back towards the heart, so there's more blood within the system, and it could all come rushing back. And the heart could expand and fill, right? I mean, it's within that mediastinum there. It can expand and fill a little bit more. But we have a fail-safe here. It's called an atrial reflex. And the atrial reflex is what protects this heart from overfilling. I don't want this heart to overfill. Okay? Because remember, what did we have here within skeletal muscle? We have a good little zone of overlap. Let's see if I can get it there. We have a good little zone of overlap. So I can go all this way and I can generate a whole hell of a lot of force. Okay? Hell of a lot of force with skeletal muscle. With cardiac muscle, it's already, sorry, I'm going backwards. It's already overlapped a little bit. Okay? So it just generates that much force, that much force, that much force. So what if this heart was allowed to overfill? Now I have more zone of overlap potential, and I can generate more force. So what if this thing's allowed to overfill a little bit more? Oh, poop. Ba-boom! Now I can generate a whole hell of a lot of force. The heart prevents too much blood from coming back and entering into the heart. And that's this atrial reflex. The atrial reflex is what prevents all that blood from entering into the atria and causing this thing called overfilling. That's an ingenious backup plan. Because blood moves forward through the system. And if I'm pumping out 70 milliliters at a chunk, I'm pushing 70 milliliters forward through the system. If I'm pushing out 50 milliliters, let's just go 60 milliliters, I'm not pushing out 70. So there's 10 milliliters, 10 units of blood that the heart's like, oh crap, I got to get 10 more units out because I know I don't have enough, because I could tell because the chemoreceptor right around the heart saying, there's not enough oxygen here, sir. I need more. So we're going to send some positive chronotropic agents down to increase the rate of contractions. Heart's going to start contracting faster. Okay. Increasing faster rate of contractions. Now that 60 milliliters is still a little bit less, but I'm catching up because now I'm increasing the number of contractions per minute. And you can get a huge volume of blood in the system that way. And I don't want the heart to overfill. Okay. If the heart overfills because there's too much blood coming back to it, that can spell disaster for the heart. And by disaster, I mean generating too much force that this individual's heart cannot take. All of that is this concept right here. Preload. Stroke volume. Heart rate. All of this affects how much blood gets ejected into the system and how much blood comes back from the system. The venous return. Positive and negative agents. Afterload. All of these things can affect how much blood gets returned to the heart. If I increase my rate of contractions and I speed up the volume of blood that I can push out of the heart, I can have a greater volume of blood entering into the systemic circulation. If I have more blood entering into systemic circulation, then I'm going to ultimately have more blood returning from systemic circulation. If I have more blood returning, the heart will expand to accept it. And it does to a point. We have that atrial reflex that prevents the heart from overfilling as much as it can. But there is some wiggle room that exists within the heart. And it's because of that zone of overlap. There is greater overlap that occurs in that zone in heart. But it's because of that overlap that exists that we don't generate a whole hell of a lot of force. As the heart stretches, I'm having less overlap occurring prior to contraction. So now I have more potential interaction between actin and myosin. So if I have more potential interaction between actin and myosin, I can create a greater amount of force. For somebody who has a weak heart, this increase in volume that comes back with increased rate because of that positive chronotrophic agent, their heart may not be able to keep up with that big volume of blood that comes back. So you're going to give them beta blockers. Beta blockers is going to prevent those bonding to those beta adrenergic receptors and ultimately help to slow down the heart rate. This whole concept that I've kind of just been sitting here chit-chatting about is what is referred to as Frank Starling's law. And what I was just chit-chatting and writing down there in pink on that previous slide is basically kind of all written right here. If you're an athlete, this is the difference between you being an athlete and you being a non-athlete individual. Your heart is an effective pumper in most cases. Okay. Your heart is an effective pumper. It can withstand those greater forces. It can withstand that greater amount of blood coming back and effectively generating enough force to pump it all back out because you are effective. You've been training that way. Your heart is healthy. So with those individuals, I mean, their end diastolic volume, their stroke volume stays about the same, may even drop a little bit because they are such an effective pumper. So really the training method of an individual can greatly affect how much blood they can pump at any given time. The bigger somebody is, let's say if you're an obese individual, all that volume of body mass has to be supplied with blood. So you're going to have an increase in blood vasculature. You're going to have an increase in blood volume to try to support and sustain all that extra mass that you're gaining. This is going to affect how hard and how fast the heart has to contract. Your heart's not an effective pumper. You don't train that thing. You've increased blood vasculature. You've increased blood volume. That's stress and strain on the heart. You probably have arteriosclerosis or atherosclerosis. So the blood vessel, instead of being that big, is that big. So now the heart has to push the same volume of blood in a much smaller hole. It has to work harder to pump greater volume out. All of these things snowball very quickly when it comes to heart health. Inotropic agents, these are going to affect the force of contraction as well. There are a number of inotropic agents. We don't need to know them. All you need to know is, what do inotropic agents affect? Inotropic agents affect how much calcium comes in to the cardiac muscle. If it's a whole heck of a lot, I increase my force of contraction. If there's not a lot of calcium that comes in, I decrease my force of contraction. Chronotropic agents, increasing the rate of contraction. Inotropic agents, increasing the force of contractions. Okay. Same stuff. What am I affecting? Epinephrine, norepinephrine, thyroid hormone. We talked about it being a chronotropic agent. Yes. It helps to increase the rate of contraction. But as you can see, it can also affect force of contraction as well. I'm not going to ask about digitalis. Okay.
Is that picture in the book?
No, it's not. It is not. Mm. Positive agents always stimulate action. Negative agents always diminish action. Positive chronotrophic agents increase the rate of contractions. Inotropic agents, positive ones, increase the force of contraction. How much blood is coming back to the heart? Preload. Is there a lot of blood coming back? Going to increase the stretch in the heart, increase in the zone of overlap, increasing my power that I can produce in that heart. How hard does the heart contract? Is there way too much calcium coming in? Or am I preventing that calcium coming in? How much force does the heart have to push against? Right behind this was all blood, right? Right behind this is all blood. Okay. It's filled. Okay, same thing here. It was filled. How much force does this have to overcome to eject blood forward through the system? That is the afterload. How much blood is returning? What is the heart doing for contractions? How much calcium is being pumped in from the extracellular space? And just exactly what does it have to push against? If you have to push open a door and there's somebody standing behind it, it's going to be a little bit more difficult to get through that door, to open that door. That is what basically afterload is. The most obvious effector of afterload is atherosclerosis, a decrease in the size of the blood vessel. And this is normal, okay? There is just some natural narrowing that can occur as you get older. Okay, especially if you have a horrible diet earlier in life and then clean it up later in life, you're going to have some plaque buildup that happens. That smaller lumen, that smaller space within that blood vessel because of that plaque buildup, well, now the only way to get over that, what's going on? Sorry, here's something upstairs. The only way to get over that smaller volume of blood that can be allowed into it is to increase my rate of contraction. Because if I have a smaller lumen, if I have a smaller space, This space is big. This space is smaller. Okay. So I have a smaller volume of blood that can be ejected out of the heart at one time. So how does the heart overcome that? It overcomes it by increasing the rate that it contracts. It increases in the firing of those nodal cells. Increasing the firing within those nodal cells, now I can increase how the muscle cells contract. And so I speed this thing up. Then we can get into ultimately a sympathetic event where I increase the rate and force of contraction. And this could be disaster, especially if you have significant blockage around the heart. What if you have blockage of a coronary artery? You're going to be able to keep up that oxygen demand to that cardiac muscle? No. Because blood moves to the heart muscle when it's relaxing. If this heart is having to speed up its contractions, the time it's relaxing is very, 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 very small. And if this has a narrow coronary artery associated with it, how in the hell is it ever going to get blood? When's it going to get oxygen? And now that tissue starts to die. As that tissue dies, the other cells around it try to pick up the pace, pick up the slack. And then they peter out. And then you have your crushing chest pain and you're in the hospital. And then you're dead. Preload, contractility, and afterload. 3 variables that can greatly affect ton of moving parts here. I don't usually ask a short answer question associated with all of these moving parts. Okay. I usually ask a number of multiple choice questions, or maybe I'd give you a scenario and I would be like, which one increase, which one's positive, which one's negative. Okay. Chronotrophic agents, they are involved with the nodal cells. Okay. Nodal cells fire the electricity to increase the rates of contraction, which affects heart rate. Ionotropic agents, the only ion I'm really worried about and concerned about is calcium. Calcium is the ion that enters into that sarcoplasm of the cardiac muscle. And if more goes in there, I have more force of contraction. And by a greater force of contraction, I can send out a greater volume of blood. Less calcium comes in, well, that diminishes it. How much blood returns back to the heart? That would increase stroke volume. If the increase came back, it would increase stroke volume because it increases the stretch. What do I have to push against? If I have narrowing of the arteries, that's a huge increase in the load that I got to push against, because now I can't push as much load as I want. Some narrowing of the arteries, some hardening of the arteries can occur as you get older. Diet plays a huge part into it. If you have a huge afterload, the heart's going to have to try to work harder and work faster to get that same amount of blood out into the system. And if stroke volume is dropping down, the only way I can fix that cardiac output is by increasing that heart rate. And again, that's going to be a positive agent. And just because that's the natural law that happens doesn't mean your heart is going to be able to hold up and maintain that. And that's when hearts start to fail. That's when you have a heart attack, angina, whatever.
Is that a multiplication sign or an addition sign? It looked like multiplication.
Right there?
Yes.
Multiplication.
Okay.
Yep. Terms there, you just should be comfortable with those terms. Matching question, multiple choice type question, that's where I would ask terminology. You should just kind of understand what the words mean. I wouldn't ask, is this associated with hypothyroidism or anything like that. If you're an athlete, you can be as low as 50. Hell, I think I know some upper level athletes are around like 48 beats per minute. Anything below, in the 40s is something that you have to pay attention to. If that's somebody that walks into your clinic, it is something that you'd have to pay attention to, because that can, below 40, you may not be effectively getting blood to certain areas of the body. So, and we'll talk about that when we start talking about the respiratory system in the next unit a little bit more, because that can affect blood pressure and whatnot. Tachycardia, just a high resting heart rate. Anything above 100 is usually tachycardia. So heart disease, fever, anxiety, things that are going to kind of get that heart rate going. But just understanding what those terminologies mean, that's what I'm going to ask. I'm not going to give you a scenario and be like, what is the chronotrophic and ionotropic agents involved in this tachycardia situation? I wouldn't necessarily ask that. Terminology, terminology.